This is the last chapter in the unit, and we're going to talk about the care of patients with non-infectious upper respiratory problems. So our priority concepts, anytime you're doing upper or lower respiratory, you're going to have gas exchange. Cellular regulation is also one of the ones we're going to look at here, a concept. And interrelated concepts are going to be nutrition and tissue integrity. So the anatomy of the nose and the sinuses. Just look over this anatomy right quick. Notice the turbinates in the nose, the vestibule, the anterior nares, all of those things. Because we're talking about the upper respiratory system, our exemplar for the cellular regulation is going to be head and neck cancer. So squamous cell carcinomas, most head and neck cancers are squamous cell carcinomas, and they usually begin with a mucosa that's chronically irritated, becoming tougher and thicker. So always think about the guys that dip. That dip that they have in the same spot in their mouth irritates that area. It's chronically irritated and it just gets white and tough and really thick. You're going to have leukoplakia and erythroplakia lesions. And what does that mean exactly? That means you're going to have white lesions and red lesions. Okay. So with those types of carcinomas, I neglected to say that you're going to have that it will be slow growing, and they usually are curable if you catch them early. But if you don't catch them early and they're untreated, these cancers can often be fatal within 2 years. Just pretty, eye-opening. Those leukoplakia lesions, they're white and usually patchy, and the erythroplakia are usually red, velvety looking patches. So this kind of cancer, if it spreads, it will be in the local lymph nodes, muscles, and the bone, and later it can get systemic. And you always have to take a sample of a lesion to have a cellular analysis done to see what stage of cancer it is and what kind it is. The most important risk factors for head and neck cancer are tobacco and alcohol use, especially in combination. Other risk factors could be overusing your voice, like singers, that's what they do for a living, coaches who maybe scream all the time. If somebody has chronic laryngitis because of that, this can be a risk factor. Of course, any kind of exposures to chemicals can also be a risk factor, and poor oral hygiene. If you have gastric reflux or oral infections, these can also lead to these types of cancers in the mouth. All right, when we're assessing for this type of cancer, we're going to look for any lumps in the mouth, the throat, or the neck area. We're going to ask the patient if they've had any problems swallowing lately. Have they had any color changes in the mouth? And you're going to actually examine the mucosa of the mouth and the tongue. Be careful when you're doing this, especially with confused patients or pediatric patients, because you don't want them to bite you. So just keep that in mind when you're assessing the inside of the mouth and the tongue. If they've had an oral lesion or sore that doesn't heal in 2 weeks, these need to be looked at. I don't know if you guys have ever had these, but I have had mouth ulcers before, but they're usually gone in less than 2 weeks. So any lesion that is not, you need to pursue further. If they have persistent ear pain on one side or persistent unexplained oral bleeding, Maybe they'll have a numbness of the mouth, the lips, or the face. Or all of a sudden their dentures don't fit right. Then these are things that may point to mouth cancer. So further assessment findings, they may be hoarse, or they may have a change in the voice quality. Once they had a deeper voice and it gets high, or they've had a higher voice and it all of a sudden is really low. Have you ever had a sore throat and it sounds like you're a female and all of a sudden it sounds like you could sing bass because your voice is so low? It's kind of like that. If they have a persistent sore throat, shortness of breath, a lack of appetite, anorexia, and weight loss, and again, if there's dentures, the change of fit of the dentures, maybe they have a burning sensation when they drink something hot or orange juice. So the priority interprofessional collaborative problems for patients with head and neck cancer include the potential for airway obstruction. And if you look at this picture here, this is actually a picture of what should be the airway. You see that tiny opening in the middle? That's all that's left of the airway. They're beginning to be occluded, and this is looking at the top of the trachea where you should be seeing vocal cords. That's where this picture is taken, and as you can see, it's almost all the way obstructed there. There is potential for aspiration, and anytime you're having trouble swallowing, or you've got a lump in that area around the trachea or around the epiglottis, your potential for aspiration increases. Of course, head and neck cancers can cause anxiety. Any kind of cancer can, and decrease self-esteem, especially those facial cancers, or if it results in maybe a trach, you're going to have some self-esteem issues. So in head and neck cancers, one thing we're going to really try to do is make sure that as these cancers grow, that they do not obstruct the airway and prevent gas exchange. This can also occur because of some types of treatments. So one of the goals we're going to have for our patients is that they maintain an adequate gas exchange and tissue oxygenation. So what kind of things can we check for that? Maybe an ABG. Is it within normal range? Let's look at their respiratory rate and their depth of respirations. Are they normal? What's our pulse ox look like? The goal of treatment, one of the goals besides keeping an open airway, is to remove or eradicate the cancer while preserving as much function of the body as possible. And things that we can do for our patients are radiation, chemotherapy, chordectomy, or a laryngectomy. So that means taking out the vocal cords and the larynx. So what you're going to consider when you're trying to decide what kind of treatment these patients need: nutrition status, what's their age, what does the effect of this tumor have on their body and the function of their body, and of course and always the patient's personal choice. So you can do things anywhere from the radiation, all the way to the removal of the larynx. So you have to do some considerations like, what about their voice? Are they going to be able to use their voice? As nurses, we're going to focus on the preoperative preparation, optimal in-house care, and discharge planning and teaching, and extensive outpatient rehab as indicated. So as we talk about radiation, just know that the cure rate is around 80% for radiation, and that radiation can be used alone or it can be used in combo with surgery and chemotherapy. It can be done before or after surgery, and most patients experience hoarseness, dysphagia, skin problems, and some impaired taste and dry mouth for a few weeks after radiation. So if they have hoarseness, you've got to let them know that this may become worse during therapy, and just reassure them that it should improve in 4 to 6 weeks after the completion of the radiation. Make sure they know that they should be resting their voice and using alternate means of communication until the effects of radiation therapy have kind of passed. This is a good time to collaborate with speech and language pathologists to help the patient communicate, okay? So most patients who have radiation in this area have sore throat and difficult swallowing, and sometimes if you will get them to gargle with saline or sucking on ice, that can kind of decrease the discomfort, and make it more comfortable. Mouthwashes and throat sprays containing lidocaine are always good to kind of numb the area, and diphenhydramine as well. The skin at the site of the radiation can also be kind of burned, so it can be red and tender, and it may actually peel during these radiation treatments. So you've got to make sure to tell the patient to avoid sun, heat, cold, and any abrasive actions such as shaving that area while they're going through the radiation therapy. They need to be taught to wear protective clothing that's soft, cotton, and use a really gentle soap like Dove to clean the area. Xerostomia, which is just dry mouth, can often be a problem, especially if the salivary glands are injured by the therapy. So they may need dental consultation, because when you don't have those salivary glands putting out that saliva, then you have risk for dental caries and oral infections, bad breath, and even changing your taste, okay? So your book does give the example that you can use fluoride gel trays at night to kind of reduce the incidence of tooth decay, and they can even be worn during radiation therapy to prevent the radiation scatter from the beam deflecting off of any like metal that you might have in your mouth. Xerostomia interventions are really just to help reduce discomfort, because if those glands are affected, it's usually not reversible. So you might tell your patient to have heavy fluid intake, particularly water, and humidification can help the discomfort. Some people may even benefit from the use of artificial saliva. Okay. Chemotherapy can be taken at the same time as radiation and in addition to surgery. And when you're doing chemotherapy and radiation, the symptoms are usually pretty magnified. All those symptoms we were talking about. Often they're so bad and so uncomfortable for the patient that the patient sometimes will ask for a break in the treatment regimen. However, breaks are related to not as good outcomes. So we have to just try to educate our patients and help them deal with these symptoms as best we can. Your book says that most chemotherapy regimens for the head and neck cancer include cisplatin, CISPLATIN, in combination with 5-FU. So those are the types of chemotherapy that are usually used in head and neck cancers. Biotherapy are really just targeted therapies with an epidermal growth factor receptor inhibitor, such as cetuximab, And it's used for patients whose tumors overexpress the receptor. Although it's a targeted therapy, it can affect normal tissue as well as those in the tumor, and as a result, some severe skin reactions are common and really difficult for the patient. And of course, we've talked about surgical management. The major type of surgery for laryngeal cancer includes cord stripping and removal of the vocal cord, or cordectomy, and a partial laryngectomy or total laryngectomy. If it's in the lymph nodes, the surgeon has to get those nodes in the neck as well as that primary tumor that's causing all the problems. So pre-op care for those patients that are going to have surgery, a cordectomy or the larynx removed, you're going to explain the procedure to them. Of course, informed consent is done by who? The physician. And you're just going to make sure that they don't have any more questions, and that they know how to self-manage after the surgery, okay? And that includes talking to them about nutrition, whether or not they're going to want feeding tubes, and all the way through plans for discharge. They'll need to understand that they may have to use a different form of communication while they're going through this, and you need to be honest with them. If you're removing the vocal cords, they need to understand that they will no longer be able to speak, okay? So post-operative care, first and always, we're going to make sure we manage that airway and that they have good gas exchange. How are we going to manage their airway post-operatively? Well, there may be lots of different things, but the one thing we know we always are going to have to do is assess. So we're going to listen to our breath sounds. We're going to keep suction equipment readily available. We're going to manage any kind of airway that may be left in place. We're going to check our pulse ox, keep our heart monitor on them. And then we might need to explain to them before the surgery about their wound, the flap, and any reconstructive tissue care that might need to be going on there. So the flap is just a piece of tissue that's taken from somewhere else on the body that kind of can help reconstruct the area. And remember that the first 24 hours after surgery are really critical. We have to evaluate that flap hourly for the first 72 hours, but those first 24 especially. We're going to monitor capillary refill, the color, the drainage, and the Doppler activity of the major blood vessels in that area. And of course, always report any changes to the surgeon immediately. Hemorrhage is always a complication that's possible after surgery, but it's really uncommon with a laryngectomy. The surgeon often places a closed surgical drain in the neck area to collect blood and drainage for the first 72 hours. And this is going to help maintain the position of that reconstructed skin flap as well. So one thing you might keep in mind is when you have this type of drain, if there's any kind of sudden stop of drainage, you're going to see if there might be a clot in there. We're going to always monitor and record how much we're getting out of there and what it looks like, and if it appears patent or not. Any kind of problems with the drain or the flap, you need to let the surgeon know. You're going to talk with the surgeon about what the policy is about emptying their drain container. Actually, you're going to look at your policy and procedure for that. But most of the surgeons, you need to know if they're okay with you milking the drain. And evidence-based practice shows that you can milk the drain, or you should milk the drain twice a day at a minimum, to keep it patent, but some surgeons absolutely do not want that. So you've got to make sure that you confer with the surgeon and make sure you know what his orders are for that. So the wound breakdown, poor nutrition, of course, always plays a part in a wound not healing, and a long smoking or alcohol history as well. We always want to do everything we can not to contaminate the wound or the radiation therapy area before surgery. So our wound, if we do have wound breakdown, we're going to approach it as the surgeon wants us to keep the wound clean and whatever we need to do to stimulate the growth of that healthy tissue back. Some wounds may be really extensive and even to the point of exposing the carotid artery. So you've just got to be aware of what's going on in that area. We've got to make sure that our skin graft looks good. We're going to watch for wound dehiscence in that area of the carotid artery especially. And we're going to evaluate whether that wound is healing or not. So when the carotid artery is in that area, just know that granulation is slow and another surgical flap may be made to cover that artery and close that wound. So just be aware that if the carotid artery is in the area, there is a risk of a rupture of that carotid artery, which means you will see bright red blood spurt quickly. And it's also possible for it to have a small leak or a continuous ooze. So what are you going to do? You're going to immediately put pressure on that wound, and you're not going to go out to call the doctor. You're going to yell for someone else to do that, okay? Because this is an emergency and they can bleed to death pretty quickly. So pain management is just like about every other pain management that you do. They may have a PCA pump for the first 1 or 2 days. If they have a feeding tube, there are liquid opioids that you can do through a feeding tube. There are oral drugs for pain if they're able to swallow, and they can tolerate that oral intake. So after the patient's discharged, they're still going to require some pain management, especially if they're receiving radiation therapy. So just know that an adjunct to pain regimen with opioids may be liquid NSAIDs. But remember, they are going to need those opioids. They're going to be hurting that bad. Tricyclic antidepressants may also be used for nerve pain or nerve root involvement. And that's part of multimodal management, pain management, like we've talked about before. Okay, so what's the problem with nutrition? That's next on our list. They're not going to have much of a taste after cancer and after their treatment begins. So they're really at risk for malnutrition for multiple reasons. And they may have to have a nasogastric tube or a G tube or a J tube placed during surgery for nutritional support while that head and neck heal. And after the intestine tract is motile, the patient can start replacing their calories and water losses orally if they're able. We're going to get the dietitian involved here, usually before surgery and available for consultation after, so that we make sure our patient's getting enough calories, enough protein, and that their water loss is calculated carefully for each patient. Where I worked, we always did this for any patient that was on tube feeding. The doctor may order a certain tube feeding, but it was standard for us to get a nutritional consult, and the nutritionist or the nutritionist would decide if they were on the correct feeding and if they were getting enough and if we were doing enough water flushes in there. Okay, speech and language rehab are pretty much a must when you have any kind of you know, facial or head type radiation. They're going to have a way to communicate, and speech therapists can help with that. There's a way to do esophageal speech is also in patients who have total laryngectomy. And this always reminds me of my little nephew, or the little boys I used to have in Sunday school that would burp and say words when they burped because it sounded interesting or funny to them. Well, that's basically what this is. They swallow air and then they burp it back up so that they can make a noise with their mouth. Unfortunately, the voice produced is really monotone, can't be raised or lowered, and it carries no pitch, really. If patients don't have adequate hearing, esophageal speech will be difficult because they need to use their mouth to shape the words as they hear them. So hearing impaired patients may need hearing aids if they're going to be able to do this esophageal speech effectively. Okay, so there are mechanical devices. Electrolarynges is what they're called, that can be used for communicating, and they're battery powered. The air inside the mouth and the throat is vibrated, and the patient moves his or her lips and tongue as usual. So the quality of speech generated is kind of robotic-like, and I know that you've probably all heard this at one time or another. You know, it's like a microphone-looking thing, and they put it up to their throat and make those vibrations to make sound. So there's a lot that goes into head and neck surgeries, and a lot to think about when you're thinking about the patient and their quality of life and how we can get them back to an acceptable level for themselves. And we just talked about their communication after the laryngectomy. Okay, it's time for you to take a break. You need to take a little break, get up and walk around, think about something else for a few minutes, and then come back. One thing to consider when evaluating whether or not a patient is kind of adjusting well to these changes, do they have the willingness to touch and care for the affected body part? Or are they disgusted by it? Do they have the willingness to use strategies to enhance their appearance? Or do they just give up and say, oh, nothing's going to help? Do they interact with the visitors and the staff and the family members? All of those things are really important. When we're teaching about home care, one thing that we need to teach about home management to prevent aspiration is to make sure that they position themselves upright for eating or drinking. They need to select foods according to their swallowing ability. So are they really just on soft foods right now? Do they need thickened liquids to make sure that they can swallow it? So they need to choose liquids and foods of the proper consistency. And of course, our dietitians can help with all of those accommodations that they might need. So what kind of education are we going to give them when they go home? They need to know how to care for that stoma. So when you think about that stoma, they can't take a normal shower like you do. They're going to need to have some kind of shield over that stoma to keep water from getting in there when they're bathing or taking a shower. They're going to have to remember to cover that stoma when they're shaving their face, the men, so that hair won't fall in it. So it's recommended that you teach them to wear a protective cover over the stoma during the day, because it kind of acts as a filter. It filters the air entering the stoma while keeping the humidity in the air, and to enhance aesthetic appearance, because it's kind of off-putting to some people to see a big hole in the neck like that. So, you might teach them about scarves, not scars, crocheted collars, and different kind of jewelry that might help to kind of hide some of that so that they can have a little more control over their appearance and to keep things from getting in that stoma. So when we're talking about communication, we've got to continue on with that communication method that was begun in the hospital. And they really need to have a medical alert bracelet on, so that if they are ever in an accident or whatever, this card will instruct the reader about providing emergency airway or resuscitation with a stoma. They have to stop smoking. I mean, that's all there is to it. They need smoking cessation. And we have to stress to them that this can decrease the risk for developing other cancers and can increase the risk for healing after the surgery, because smoking really does decrease the healing. So psychosocial preparation, there's going to be many changes in their lives, and some of them we won't even think about ahead of time. We're going to have to kind of help them deal with it as they go along. But we do need to stress to them to return to as normal a lifestyle as they possibly can, and to resume most of their usual activities within 4 to 6 weeks after surgery. Sometimes they may need a little longer than that, but they need to be trying to work towards getting back to their normal. So remember that a patient with a total laryngectomy can't produce sounds during laughing and crying. And mucus secretions may appear unexpectedly with these emotions, and they'll start coughing and sneezing. The mucus can be embarrassing, and the patient needs to know when they're crying that they need to be prepared to cover up their stoma with a handkerchief or a gauze. And of course, they may have some problems with swallowing too. They may have to be taught how to use their feeding tubes and how to best do it in a private way if they are in public. All their healthcare resources need to be given to them before they leave a hospital. So cancer of the nose and sinuses. These can be malignant or benign, but they're usually benign. Occasionally they're malignant, but they're usually benign in the nose and the sinuses. You get these whenever there's exposure, a lot of exposure to dust, to flour, nickel, chromium dust, mustard gas, and radium. They're awfully slow onset for sinusitis. So you may have things like, for sinus surgery, you may have things like that resemble sinusitis, like persistent nasal obstructions, drainage, maybe a little bloody discharge, and some pain that persist after the sinusitis is treated. So how do we identify these types of cancer? We're going to find them on x-rays, CTs, or MRIs, and then they'll do a biopsy to confirm that it is cancer. Usually, nasopharyngeal cancers are removed by surgery, and they can have radiation and chemotherapy in conjunction with that. So what kind of problems do we see after they have nose or sinus surgery? There's problems with the body image, sometimes with speech, They may have altered nutrition, especially when the maxilla and the floor of the nose are involved in the surgery. And they often have a change in taste and smell, which leads to poor nutrition. In the post-op period, you're going to have the same type assessments that you would with just about anything else. You're going to make sure they continue to have a patent airway. Are they bleeding? We're going to provide any wound care that needs to be done. We're going to assess their nutritional status, perform trach care if we need to. We're going to perform mouth care. With these kind of surgeries, though, your mouth care needs to be with saline irrigations. And of course, we're going to assess for pain and infection. And one of the main collaborations we'll do is with the dietitian to make sure that we get foods that they can eat. So do they need a soft diet? And also foods that will promote healing in the patient. So fracture of the nose, look at the displacement of this bone and cartilage in this guy. It can cause airway obstruction, of course cosmetic deformities, and potentially a source for infection. So anytime you have a nasal fracture, one of the things that you need to assess for is cerebrospinal fluid coming out of the nose. Well, if something is running out of the nose and it's clear, you're not sure what it is, how do we tell if it's cerebrospinal fluid? Well, one thing you can do is do a dipstick and test for glucose. If it has glucose in it, it's most likely cerebrospinal fluid. You can also take a piece of filter paper and catch a little bit on it, and when it dries, it will have a yellow halo appearance. Okay, so what kind of interventions do we do? A closed reduction can be done, which is just moving the bones by palpating to realign them. And it's usually done under general anesthesia because it's super painful. Needs to be done within the first 24 hours. Otherwise, the edema and scar formation can prevent you from aligning it correctly. So after 24 hours, it's more difficult to align. So if they don't do it in the first 24 hours, they may go ahead and just delay it for several days until that edema is gone. And simple fractures that are closed, not open to the outside air, may not need surgical intervention. And your management might focus on pain relief and a cold compress to decrease swelling. But in this picture, if the nose is displaced like this guy's is, you really need to see a physician, and they're probably going to have to try to straighten that up. So what is rhinoplasty? That is surgical reconstruction of the nose, and that's if you cannot get that nose straightened back up by a closed reduction. And it can be for like a bone fracture, like the nose fracture here, or it can be done just as a let's make somebody look prettier surgery. Okay. After the surgery, of course, we're going to look for edema and bleeding. We're going to check those vital signs every 4 hours until the patient is discharged. A lot of times, if they have an uncomplicated surgery, they can go home the same day. And we're going to have to, of course, instruct the patient on how to care for themselves at home. So we want them to kind of stay in a semi-Fowler's position, going to move slowly, use those cold compresses to keep the swelling down, eat soft foods, and make sure that they have a gag reflex before they start to really eat anything. Make sure they know to drink at least 2,500 milliliters a day of fluids, and we're going to tell them to avoid any forceful coughing, any straining during a bowel movement. not to sniff upward or blow the nose, and not to sneeze with the mouth closed for the first few days after the packing is removed. So that sneezing, if they absolutely have to sneeze, their mouth needs to be wide open so that doesn't cause any pressure in that nose area. They don't need anything that might make them bleed, like aspirin or NSAIDs. They're going to have to take antibiotics to prevent infection, and they really should use a humidifier to keep that from drying out in there. They need to know, educate them that they're not going to see the final results with all the swelling gone until maybe 6 to even 12 months after the surgery. Okay, so nasoseptoplasty. So this might be needed if a patient has a deviated septum, and major deviations of the septum can actually obstruct the nasal passageways and interfere with airflow and sinus drainage. So sometimes it's necessary to have these type surgeries done, and the nursing care is just very similar to the rhinoplasty. So again, post-op care after rhinoplasty, observe for edema and bleeding, check those vital signs every 4 hours, and change that drip pad under the nose as needed. Epistaxis, what does that mean? That's a nosebleed, and it's a common problem. If it happens after they've had nasal surgery, or even if it happens just any time, and you can't get it to stop, it may have to be cauterized. You may have to go up. They may have to go up in there with cautery and cauterize those capillaries and pack that nose. Posterior nasal bleeding can be an emergency. You're going to assess for respiratory distress. Are they tolerating the packing or the tubes? You're going to make sure that they have humidity going. They may need oxygen, bed rest, antibiotics, and pain medication. It can be very severe, or it can be, just a common nosebleed that stops pretty easily. The girl here has actually a nasal tampon in her nose, and they can be laced with cocaine, which actually helps to stop the bleeding in there. They're going to, of course, once we get it stopped, avoid those nose blowing, any aspirin or NSAIDs, and any strenuous activity such as heavy lifting for at least a month. If you have a bunch of crusties on your nose from the nosebleed, you can put a little Vaseline on there to clear it off, but make sure you tell them not to use a whole bunch, because you may inhale some of that jelly into the lungs, and that's a big risk for pneumonia. So just a little on the external nares to keep that drainage softened up, and then maybe wipe it off with a warm washcloth. Facial trauma, man, this can be really, really bad. So our priority action is always airway assessment if you have a major facial trauma. What are some signs and symptoms that they may be having trouble with their airway? Stridor. We listened to stridor earlier. That's just an upper airway obstruction causing that noise. Are they short of breath? Are they really anxious, restless? Are they having hypoxia and hypercarbia? Is their pulse ox okay? Do they have cyanosis or lose consciousness? So you can see with this guy, and actually around his mouth is not too bad, but how facial trauma can be really bad on the airway. So we talked about the airway assessment in those facial trauma patients. We also may need to anticipate the need for emergency intubation. So if you know a patient is coming into your emergency room with excessive facial trauma, You might need to make sure you have an intubation tray as well as a tracheotomy tray and a cricothyroidotomy tray. Okay. One thing that may need to be done is fixed occlusion of the wounds, which just really means wiring the mouth together. And you're going to have to watch for problems with that. Can you guess what some of the problems may be? I mean, you're going to have poor oral care. You can have jawbone infection. You may end up having to have dead tissue removed. They probably really need IV therapy, and a long period with the jaws in a fixed position especially will require that. So, and open reduction with internal fixation procedure might have to be done on extensive jaw fractures. So there's just all kinds of problems that you need to look for with those facial traumas. And of course, debridement, especially on over-end care. Once we kind of see what's going to be healing there, those wounds may need to be debrided to continue on with the healing of those massive facial traumas. Obstructive sleep apnea. That's when your breathing is disrupted during sleep, and it is usually because of airway closure, upper airway closure. And some of the signs and symptoms would be excessive daytime sleepiness, inability to concentrate, and irritability. It's also found that hypertension can be related to obstructive sleep apnea. There are some non-surgical management, like change of sleep position, and that is one of the things. When I worked in the respiratory department, we had the sleep lab right there with us, and one of the things that our physician prescribed would be to sew a tennis ball into the back of the t-shirt of the patient so that they could not roll over on their back. They would have to side lie to sleep. Weight loss is always helpful, and positive pressure ventilation in the form of a BiPAP can also work wonders for obstructive sleep apnea. There are some surgical managements that you can do for obstructive sleep apnea, like removing the adenoids, removing the uvula, or removing part of the uvula, the palate, and the pharynx. So all of those can be done for treatments of sleep apnea. This is a positive airway pressure picture, and you'll see the picture C is usually what we use in the hospital. We'll use a full face mask over the nose and mouth, but for home use, A is a nasal mask, and B is nasal pillows, which those, a lot of the patients that I had when I did respiratory care and home care liked the nasal pillows because of the way they fit into the nose. They're not covering the whole face, and you see how the tubing goes up between the eyes and over the head, and it's secured that way, so you don't have that tubing to deal with down on your body while you're trying to sleep. So, disorders of the larynx. You've got vocal cord paralysis, vocal cord nodules and polyps, and laryngeal trauma. Okay, so you see the vocal cords here, and it's pointing to the glottal space and the vocal folds. You see those knots there? That's normal. To the left and the right of those yellow lines that are going through, those are normal. And matter of fact, that you look for those to make sure that you're in the correct anatomical position for intubation. And we'll talk about that later in critical care. So upper airway obstruction, you're going to have a block in the airflow through the nose, the mouth, the pharynx, or the larynx. And these are life-threatening emergencies, okay? So whenever you hear that stridery sound, that's really it can be a life-threatening emergency. and when it stops, it definitely is a life-threatening emergency. Because a lot of times you'll have an obstruction of the upper airway, and you've got a little bit of passage of air around it, and then the obstruction moves and it totally occludes the airway. So early recognition is absolutely essential to prevent any further complications, including respiratory and cardiac arrest. So what are we going to do for these people? We need to assess what's causing the obstruction. Is it epiglottitis? Is it a foreign object? I mean, what is causing the problem? Is it trauma to the upper airway? So we have to maintain a patent airway and make sure that we're able to ventilate the patient. So are they going to need a cricothyroidectomy? Do they need endotracheal intubation? You can do nasotracheal or orotracheal, and nasotracheal might be chosen if the jaw is broken or the mouth area has a lot of trauma, or do they need a tracheotomy? So what is a cricothyroidotomy? So a cricothyroidotomy is an incision made through the skin and the cricothyroid membrane to establish a patent airway during life-threatening situations. It's temporary. It's a temporary airway. So a permanent tracheotomy should be placed within 24 hours. You can do what's called a needle cricothyroidotomy, and it really shouldn't be used for any more than about 40 minutes. After that time, the carbon dioxide tends to accumulate because it's so small. You can see if you were using a needle, you wouldn't be able to force out enough air to clear the CO2. So a cricothyroidotomy is just a really quick thing that you might do in the emergency room to establish an airway, and then move on to a tracheotomy or intubation, depending on which you can do according to what's wrong with the patient. So your assignment for this video, you will have a case study, and when you're answering the question, especially if it's an open response question, I expect for you to answer it in depth and accurately, okay? And then also there are some multiple choice and select all apply questions to answer after this video. A good portion of what we're going to do for this unit is going to be in lab, because there are so many, you know, oxygen modalities we need to look at, trach care, that kind of thing. So go ahead and get those things done, and I'll see you in class soon.